Good evening, everyone, and welcome to this evening's update on bladder cancer and upper tract urothelial cancer. My name is Grace Linehan, and I'm the Medical Liaison Officer at the Australian Prostate Centre. I'd like to begin by acknowledging the Kulin Nations, traditional owners and custodians on the land on which we're gathering this evening, and I also pay my respects to their elders, past and present. So before we begin, I'm going to give you a quick overview of the services and procedures available at APC before we hand over to Praz. APC is a not-for-profit outpatient urology service, and we're located in North Melbourne. We specialise in prostate cancer while also offering a full suite of general urology, uro-oncology, prostate cancer survivorship, and allied health services. We also provide pelvic floor physiotherapy and a continence clinic. This multidisciplinary approach to patient care means appointments can be made with minimum waiting times, and patients don't need to travel between different hospitals to access the services. And we also have patients attend our clinic from all across Victoria, and some even come from interstate as well. And it's good for you to know that your patients can come to APC at any stage of their cancer or their condition, and they can be connected to our team of leading urologists, medical oncologists, radiation oncologists, endocrinologist, pain physician, prostate cancer GP, psychologist, urology nurse practitioners and urology nurse consultants, pelvic floor physiotherapists, and exercise physiologists. They're all located on site, and we have a gym at the clinic as well. And as a not-for-profit organisation, it's our policy to keep out-of-pocket costs as low as we possibly can, and we can bulk bill urology consultations for patients experiencing financial hardship. We prioritise timely access to care, and we keep our wait list at 1 to 3 weeks for routine referrals, but rapid access is available for urgent referrals, and they are generally seen within 1 week. Now, just to go over some brief housekeeping, please make sure you keep your microphones on mute throughout the presentation. And we do want to make this session as interactive as possible. So if you do have any questions for our speaker, Praz, this evening, or case studies you want to ask him about, you can type them into the chat box. You'll see them either underneath at the bottom of your screen, or sometimes they can be at the side of your screen as well. You can type them in there, and I'll ask Praz either throughout the session at an appropriate time or during the Q&A time at the end as well. You'll have heard this event is being recorded, and at the end of the session, as you're leaving the meeting, an evaluation form will appear on your screen. If you could take 2 minutes to fill it out, we'd really appreciate your feedback. And as you can see there at the bottom of your screen, the RACGP feedback form link is there as well. So I'm going to, before I give your intro to Praz, I'm just going to go through the learning outcomes for this evening. So by the end of this activity, participants will be able to describe the contemporary management of bladder cancer and upper tract urothelial cancer, and secondly, to list the red flags that recommend immediate referral to a specialist. So I'm delighted to welcome our speaker for this evening. Dr. Praz Satasivam is a urological surgeon with expertise in general urology and a subspecialty focus in open and robotic surgery for urological cancers. Praz has both a fellowship of the Royal Australasian College of Surgeons and membership of the Society of Urologic Oncology. As a senior lecturer at the University of Melbourne, Praz supervises research students through the university's MDRP program, and also serves as urology training supervisor at Northern Health and deputy chair of training in Victoria. After completing his postgraduate surgical training in Victoria, Praz completed a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Centre in New York. And in addition to consulting at the Australian Prostate Centre, Praz consults privately in Camberwell, Carlton North, Craigieburn, and Ping. He operates privately at Epworth Richmond and Epworth Freemasons, Northern Private Hospital, and at Cabrini Hospital in Malvern. So I'm going to stop sharing my screen and hand over to Praz. Thanks, Praz, whenever you're ready.
Good evening, everyone. Thank you for this opportunity to speak to you all. I'm just going to share my presentation. Just bear with me 1 second. There we go. Okay. Okay, so Today's topic is going to be on bladder and upper tract urothelial carcinoma specifically. Just want to start by uh, stating I don't have any conflicts of interest. In terms of why I'm qualified to talk to you about this, as has already been described. I do have various qualifications, including Uro-Oncology Fellowship, but also I was the lead reviewer for the recent Understanding Bladder Cancer um, handbook put out by the Cancer Council. Um, Starting with bladder urothelial carcinoma. Urothelial carcinoma is the most common subtype. About 5% are SCCs, fewer than those adenocarcinomas. Most people are diagnosed at age 70, and men are far more common than women. The most common presentation is visible hematuria in 20%, but microscopic in 0.5 to 10%. Having irritative lower urinary symptoms, we're talking about urgency, frequency, uh, um, nocturia, um, increase the risk factors. So it can't always assume that these symptoms are necessarily related to BPH or recurrent urinary infections, especially if there are certain risk factors associated with the presentation. And these include smoking, which increases the risk up to fourfold, and certain industrial exposures, aromatic hydrocarbons, aniline dyes, radiation exposure, which can have up to a 30-year, 15 to 30-year latency, chronic cystitis, cyclophosphamide, and family history. The urothelial carcinoma goes down two separate genetic pathways to form what we see as low-grade and high-grade urothelial carcinoma on histology. The top image is a low-grade lesion. The specific genetic markers have been found to be loss of genetic material on chromosome 9, as well as certain alterations in other genes. High-grade tumors are far more aggressive, and they're the ones that we are worried about, particularly because they pose a threat to life, and they are associated with various tumor suppressor gene alterations, including p53 and RB, and multiple chromosome losses. And you can hopefully see the more solid, aggressive-looking appearance of the lower images, which are of a high-grade tumor. But again, endoscopic appearance isn't the be-all and end-all. It does require histology for us to be 100% sure of what we're dealing with. So we'll start with a case study. This is a 91-year-old lady who all of these case studies are actual patients as well. So this is a 91-year-old lady who recently presented with 1 week of visible hematuria, but no other urinary symptoms. She's got a past history of metastatic pancreatic head neuroendocrine tumor, as well as gastroesophageal reflux disease, but no other comorbidities. She lives with a cat, independent, and was a social smoker about 40 years ago. Um, what's the workup for someone who presents in this manner? Urine cytology is an easy test to order. It's up to 100% specific, meaning that if it's positive, then the patient more than likely has urothelial carcinoma, but it's only 50% sensitive. So a negative test doesn't necessarily rule out the diagnosis. And you can get false positives through instrumentation, presence of stones, urinary tract infections. Um, and in addition to that, some form of imaging, CT intravenous parallelogram or renal tract ultrasound if there's any contraindication to contrast. But CT is ideal. Will give us an idea as to what we're dealing with, whether it's an upper tract or bladder cause, if there is a large tumor. Now, the CT is far less sensitive for the bladder as it is for the upper tract. And so a negative CT does not exclude bladder cancer, and all patients must undergo cystoscopy if there's any visible hematuria or concern for bladder cancer as a diagnosis. There are other markers that are in the that are available, but these are used more so in the experimental setting. CX bladder is probably the one most commonly used in the public hospital setting. I know it's used certainly at Northern and at Monash, and it's it's used as a triage tool to try and determine which patients really do need a cystoscopy, whether those versus those who have negative imaging and potentially could just be monitored. And then finally, cystoscopy and transurethral resection of any tumor at the bladder. The images here show the initial tumor. You can see the loop of the resection instrument and the area on the bladder wall once the tumor's been uh, removed. And then the final image D shows a deeper biopsy taken of the muscle fiber to ensure that there is adequate staging, which I'll get into in a moment. The most important thing to remember is that at an initial cystoscopy, 40% of patients will still have residual tumor that isn't picked up. And especially for high-grade tumors, this mandates repeat resection within a 4 to 6 week period. And in those settings, up to 30% of patients are even upstaged to muscle invasive disease or beyond in the high-grade setting. Sorry. So the imaging. CT intravenous pyelogram, you can see a very obvious large lesion arising from the right lateral wall of the bladder here on imaging. So obviously the patient proceeded directly to transurethral resection of the tumor, and the tumor fragments came back showing high-grade papillary urothelial carcinoma, PT1, so limited to the lamina propria, which I'll explain in a minute. Importantly, the deep muscle was not involved. And when I do initial TURBTs, I always take separate bladder biopsies with cold cut biopsy forceps to minimize any cautery effect, so the pathologist can be pretty confident in their assessment of the deeper biopsies of the muscle tissue to ensure that there is no residual tumor. So, staging. This image shows the T staging on the right. You can see it goes from superficial TIS and TA limited to the urothelium to T1 where the tumor is moving into the lamina propria, then T2, A and B going into the superficial and deeper muscles, so deeper layers of the detrusor muscle. And once it hits the serosa and moves into perivesical fat, it moves into T3 and then into the prostate or pubic bone, it's T4. And obviously, with the highest T stage, there's worse prognosis and more challenging management. And nodal status is related to presence of where positive nodes are seen along the chain from the level of the up to the level of the aortic bifurcation and beyond, and metastatic disease is obviously distant metastases, which I haven't included in a picture here. With bladder cancer, we use a risk stratification based on multiple factors to then help guide our treatment. Low risk patients are those that have a single lesion that is superficial, low grade, small, no associated carcinoma in situ, and the patient is younger, less than 70 years. So they can be managed more expectantly than patients who are either intermediate or high risk. The high risk patients being anyone with high grade T1 lesions without carcinoma in situ, or all patients with carcinoma in situ. And then there's a very high risk category, which includes the above categories plus additional risk factors, whether they're older than 70, whether they've had multiple tumors, or whether they have a tumor, their initial tumor was greater than 3 centimeters. So back to our patient. Her initial TURBT revealed a high-grade T1 lesion. She underwent a repeat TURBT 6 weeks later, at which time she was noted to have multiple papillary recurrences. These were all high-grade, but superficial TA rather than going into the lamina propria. However, this time around, there was a carcinoma in situ present. So she falls into the category of very high risk. And she began a course of treatment called BCG. Before I talk about BCG, I'll talk about the overall classification of non-muscle invasive bladder cancer. We talk about cancer as either muscle invasive or non-muscle invasive as broad categories. And non-muscle invasive could then be broken down into low-grade lesions or high-grade, which are either superficial or starting to invade. no lesion that invades into the lamina propria is low grade by definition. So they're all TA. Um, so in these treatments, patients can sometimes get a single dose of mitomycin C delivered directly into the bladder as a chemotherapeutic agent, which helps reduce the risk of recurrences. And if they then have recurrent disease, they could have further courses of mitomycin C or commence treatment with BCG. These patients require all patients with bladder cancer require surveillance cystoscopies, and for low-grade tumors, that's initially at 3 months, and if that's negative, at 12 months, and then yearly for about 5 years. Some clinicians will continue to monitor beyond 5 years. Others will deal with it, case by case basis. The risk of recurrence is about 30% for low-risk patients, according to the EORT's classification I mentioned previously, and it's about 50 to 70% for patients who fall into the intermediate risk category. The risk of progression to muscle-invasive bladder cancer is about 5% if the patients are intermediate risk. Now, moving into the high-grade lesions that are non-muscle invasive, so that's either TA or T1, the treatment is BCG or early cystectomy. If patients have BCG, which is an installation of an agent into the bladder to stimulate the immune system to kill cancer cells, if this fails the first time around, you can either have a second induction course, or in most cases, unless there are contraindications, the patient should proceed to cystectomy. For successful response, the follow-up is more aggressive than for low grade, with cystoscopies every 3 months for at least 2 years, and then stepping down over the subsequent years, but never really stopping. The risk of recurrence is about 50% if there's a solitary tumor. If it's multifocal and there's carcinoma in situ, it's up to 80%. And there's a 70% risk of progression to muscle invasive bladder cancer if it's a solitary tumor. It's up to 50% if it's multifocal and CIS is present. So for patients who have carcinoma in situ, which is a high-grade lesion but doesn't present as a papillary lesion like we saw in the earlier slides, but rather as flat sheets of erythematous-looking tissue. The treatment is BCG with maintenance course and then regular cystoscopies. The risk of recurrence and progression to muscle-invasive disease is higher than if it's simply a high-grade lesion without carcinoma in situ. So, although it looks less dangerous when you look at it at the time of resection, it is a very aggressive subtype. And there are special scenarios, such as if there is a tumor forming within a bladder diverticulum. By definition, a bladder diverticulum forms as an outpouching of mucosa through a gap in the muscles. That's arisen due to, in most cases, long-standing bladder outlet obstruction causing hypertrophy of the muscle bundles and then an outpouching of tissue between them. By definition, because there's no muscle layer, if it goes straight from the urothelium to T3 disease outside the bladder. And so those patients have to be monitored very closely, and decisions made that take into account this possibility. If there's tumor at the ureteric orifice, when resecting it, you have to be very careful about ureteric orifice stenosis or seeding, as well as the increased risk of upper tract urothelial carcinoma. I had a patient just 2 weeks ago who came in with a very small, superficial looking lesion that was just above his left ureteric orifice. And as I was resecting it, I could tell that with how easily it came off, that it was seemed to be recently adherent to the wall of the bladder and wasn't really and looked like it had been seeded from somewhere else. And so I arranged, he only came in with an ultrasound. So I arranged a CT IVP, and he had extensive tumor in his left ureter, without any hydronephrosis, because it wasn't causing complete obstruction. That's why there was no hydronephrosis on the ultrasound. So he's going to be proceeding to a nephroureterectomy shortly. And his presentation was completely incidental. The ultrasound was done for other reasons, unrelated to his lower urinary tract. So he's pretty lucky. Finally, if there's bladder outlet obstruction, it is possible to do a simultaneous TURP for a patient who's having a TURBT. As long as it's low grade and superficial, this does not increase the risk of seeding in the prostate. So, BCG. Bacillus calmette-guerin. This is the live attenuated bacillus vaccine strain of Mycobacterium bovis, which is used as a TB vaccine. It binds to fibronectin in the bladder and incites a massive local inflammatory Th1 response. And we use it for carcinoma in situ, high-grade Ta lesions, or T1. It decreases the risk of recurrence by about 40% and the risk of progression by about 25%. The protocol is a 6-week induction course. The patient comes into the center. It's not APC, but it is delivered in the hospital setting on the chemotherapy wards. A catheter is placed in the bladder. Tests are done to make sure there's no concurrent infection or bleeding, and then a dose of BCG is given into the bladder. The patient's supposed to hold on to that for an hour, and then they void that spontaneously. After the induction course, if there is evidence that the disease is under control, there's no evidence of recurrence or progression on the first post-induction BCG check, then they'll usually go on to maintenance, which is three weekly installations every 3 months for 6 months, and then every 6 months for up to 3 years. There are lots of minor adverse events that patients can manage quite easily, but there are some rare adverse events, including a patient developing a contracted bladder and bothersome lower urinary symptoms as a result of that. Very rarely they can develop granulomatous prostatitis or epididymitis, and a very rare situation is BCG sepsis, which can be life-threatening. I have only seen one case of BCG sepsis, and that was when I was a registrar. At one of the public hospitals in Melbourne. The usual uh, urology nurse on that particular unit was on leave, and the nurse covering him didn't, was administering BCG, did a traumatic catheter insertion, there was bleeding. She contacted one of the residents to ask whether it was safe to proceed with BCG. He didn't check with anyone senior. He just said, "Oh yeah, should be fine."
Raz, you've just dropped out. You might need to, if you can hear me, you might need to leave.
Check.
Oh, you're back. Raz, you just dropped out there for just when you were saying that the or the registrar or the resident contacted the senior. Oh, sorry, hadn't contacted. The nurse had contacted the resident, and they had said it was fine to proceed, and it dropped
Sure,
out then
sure.
for me anyway. So
Okay, well, I'll say that again. So then the
sorry.
patient was given a course of with the traumatic catheter, there was a breach of the mucosa, and the BCG went into the bloodstream and then caused a disseminated, basically tuberculosis. And so the patient needed to go to ICU, have a course of steroids, was in hospital for a month, and then required, very sick, and then required another 6 months of, up to 6 months of anti-TB medication at home. So very rare, but if it's administered in an institution where people are trained, know what they're doing, and are careful and follow correct protocols, then the risk is very low. And so I haven't seen another episode like this since in the last 15 years. So it's uh, just to be aware of. So when BCG fails, this patient's either classified as BCG refractory, in that they've had the BCG, initial cystoscopy shows there's still disease there, or there's disease that develops during maintenance therapy. They may have a relapse, so they're disease-free at 6 months, but then subsequent cystoscopy shows a relapse, or they're completely unresponsive to the tumor. And in that situation, the gold standard is radical cystectomy. But if they're unfit for cystectomy, there is the option of giving a second repeat BCG course. There are immunotherapeutic agents, and there are clinical trials. One treatment that has recently been shown to be quite useful is giving intravesical gemcitabine with docetaxel. chemotherapy, and administered in a similar manner to BCG. And these patients can show a significant recurrence-free survival at 2 years, and at 5 years, 75% of patients have still managed to avoid cystectomy. So back to our patient, she didn't have any issues during the BCG, but on her first post-induction BCG cystoscopy, she was known to have multiple solid recurrences at the dome and the right lateral wall, and the histology confirmed persistent high-grade TA urothelial carcinoma. At her age, at 91, she's not, even though she has minimal other medical comorbidities, she's not a perfect candidate for cystectomy because the disease is not yet muscle invasive. She's doesn't meet the criteria for radical radiotherapy, and so she commenced, and she's not an ideal candidate for chemotherapy either. She's now commenced a course of intravesical gemcitabine with docetaxel, and hopefully this will be enough to bring the disease under control. Um, Excuse me for one moment. Someone has stepped into my room. Sorry. So I'm in a meeting another time. Yeah, we'll come back next week. Thank you. I thought they usually come on Friday. Apologies for that. The second case study. This is a 65-year-old gentleman with several months of bothersome lower urinary symptoms and visible hematuria. He's an ex-smoker of 10 cigarettes a day for the last 20 years. He doesn't have any industrial exposures that would increase his risk of urothelial carcinoma. And his urine on presentation showed some E. coli. He's a retired soldier, lives with his wife. His past history includes ischemic heart disease, aortic stenosis, hypertension, and a shrapnel injury to his eye. He's he undergoes a basic workup, has positive urine cytology. An ultrasound shows two lesions in his bladder, one measuring 7.8 centimeters and the other measuring 1.8 centimeters. He goes on to have a CT intravenous pyelogram in chest, and you can see the lesions again, measured slightly differently, but very obvious here on the CT. You can also see on this image a bit of right-sided hydroureter, although the slices don't show the kidney. He had hydronephrosis with an atrophic kidney on that side. There's no evidence of any metastatic disease, and subsequent transurethral resection revealed a high-grade T2 muscle-invasive bladder cancer. So, muscle-invasive bladder cancer, if left untreated, has a 3% 5-year survival. So, and in the metastatic setting, the mean survival is only 14 months. There's an increased risk of death and, oh, sorry, of progression and death if you delay treatment by greater than 3 months. So once it's diagnosed, you need to get your skates on pretty much. 20 to 35% of patients who undergo cystectomy have lymph node metastases at that time, which may not necessarily be picked up on staging. And when it spreads, it goes to liver, lung, bone, and adrenal glands. So treatment is gold standard treatment is cystectomy with lymphadenectomy plus or minus neoadjuvant or adjuvant chemotherapy. Neoadjuvant is ideal, mostly because of the nature of the surgery is such that some patients have a very slow recovery and no longer become a candidate for adjuvant chemotherapy and therefore miss out on their chemotherapy. Some people argue that giving them neoadjuvant chemotherapy deconditions them to the point that they have more complications as a result of the cystectomy, but that has been borne out in multiple studies as not being true, but rather that the patients, this cohort of patients greater than 70 with smoking-related comorbidities, including central and peripheral vascular disease, that's the main reason why they struggle with this sort of major surgery. The other equivalent treatment is bladder preservation with trimodal therapy, meaning maximal transurethral resection of the tumor, a radiosensitizing course of chemotherapy followed by radiotherapy. Some patients may be a candidate for partial cystectomy plus or minus chemotherapy. Some patients, if they're not candidates for either that, would undergo palliative radiotherapy. So urinary diversion. Once we take the bladder out, the urine has to go somewhere. The traditional and most common approach is to use an ileal conduit. It's easier to perform. There are fewer complications. There's minimal requirement for patient compliance or dexterity. But the downside is it's non-continent and there are permanent changes to the external appearance of the patient requiring a stoma bag for life. Um, the alternative is a neobladder, which is a continent diversion. There's no stoma bag. The patient maintains their body image. If there are any problems with it down the track, you can convert it to an ileal conduit if needed, based on the nature of how we construct it, which I'll show you in a second. But the downside is it's technically challenging. There are more complications. The follow-up is indefinite. The patient has to be very motivated and compliant with the instructions you give them. They need to be mobile and dexterous, and they need to be uh, clued up enough to understand how it works and how to manage any complications. A colleague of mine once described the two of them as the ileal conduit is like your Toyota Corolla. It'll do the job. It's very reliable. It's not that fancy, but it'll get you from A to B, and you can and it's not going to break down. The neobladder is your Ferrari. Looks great, but requires a lot of maintenance, and I thought that was a nice analogy. I I did neobladders in fellowship, but it's one of those procedures that requires a team of nursing and medical staff working together to make sure it works well. And so I don't perform these in the private sector or public sector and defer to colleagues who have that set up. So, but I can tell you how it's constructed. You can see in the first image here a segment of ileum, usually about a meter, is half a meter to a meter is separated. We tie off both ends, make a longitudinal incision, and then suture the back wall of that, and then suture the ends of that together to create a pouch. The ureters are plugged into the what's called the chimney at the top, and this chimney is what's converted into an ileal conduit if the patient has complications from the neobladder that can't be managed. Um, Once everything is stitched together, the bladder is anastomosed to the urethra in a similar fashion to how we would do it after a radical prostatectomy. And then the patient has multiple drains in situ to ensure that everything heals adequately. And those drains are taken out sequentially in the postoperative period. As you can see, there are a lot of different complications from having islet conduits and neobladders. Um, this is our most comorbid procedure. This is the one which has the highest risk of death in the first 30 days. It's something that should not be embarked upon lightly. Um, and but you can if you get in and this is why we recommend it for so many patients with high grade T1 disease. If you can get in early and before the disease progresses to the point where it's outside the bladder, the patient will do better long term. So back to our patient, he was offered neoadjuvant cisplatin and gemcitabine, followed by radical cystoprostatectomy. He declined. He did not want a urinary diversion. He was not a candidate for a partial cystectomy because the tumor was adjacent to and enclosing his ureteric orifice, and so therefore the decision was made that he could proceed to trimodal therapy. So he had 6 cycles of gemcitabine with cisplatin, followed by 32 fractions of radiotherapy. So trimodal therapy, it's curative intent. The patient has their initial TURBT with confirmation of no residual disease, followed by some radiosensitizing chemotherapy, followed by radiotherapy. If there's carcinoma in situ, this approach is less effective. Likewise, if there's hydronephrosis or a small capacity bladder, and there's a 30% failure rate with subsequent cystectomy, and it requires long-term surveillance. Another option is partial cystectomy with a 2 centimeter margin plus or minus pelvic lymph node dissection, plus or minus chemotherapy. These are for tumors at the dome, for example, or within a diverticulum, where you can be confident that you can get the 2 centimeter margin around it. Still, very high recurrence rate, similar 5-year overall survival. Patients who are unfit or unwilling to have cystectomy can have some palliative radiotherapy, but there's a small, very small chance of cure with this. So back to our patient. He underwent his first post chemoradiotherapy TURBT showed some high grade disease. Second, he remained on surveillance. His second biopsy was benign. His third showed some more high grade disease. His fourth was benign. During this time, his left kidney became obstructed, and he required a nephrostomy and antegrade stent placement. And this was mostly due to radiation changes in his bladder that had caused obstruction to his left ureteric orifice, as well as repeated TURBTs for recurrent disease in the context of radiotherapy, causing scarring and contraction of his bladder. Um, this was around about COVID times, and there was a BCG shortage. So his options were limited. He developed evidence of reflux and renal impairment and became catheter dependent. And so he finally agreed to salvage cystectomy and proceeded to a right nephroureterectomy at the same time, given that this was a non-functioning right kidney, and to ensure complete clearance. And he had an ileal conduit. So, systemic therapy for muscle invasive bladder cancer. Now, this space has seen a remarkable transformation in recent years from platinum-based chemotherapy to newer agents, and the standard of care now is um, uh, enfortumab vedotin (EV) plus pembrolizumab, which is a checkpoint inhibitor. So EV is an antibody targeting a cell adhesion molecule called nectin-4, and then that uh, has linked to it a microtubule inhibitor conjugate. So what that means is this is basically like a bomb. The bomb finds its target cell and drops it. It's like a bomber. It finds its target and drops a payload, and that payload disrupts the microtubules in the cell, causes the cell to die. The reason this has become first-line therapy is that the overall survival versus platinum based chemotherapy, which used to be standard of care, is significant, as well as there being a higher complete response. However, having said that, the toxicities with EV and Pembro are very significant. Patients can die on this treatment, um, and have to be, monitored very, very closely. I won't go into too much more detail. I'm not a medical oncologist, so I'm relying on secondhand knowledge from their experience. So the second option, which is systemic cisplatin-based chemotherapy, which used to be standard of care, there's a 20% um, uh, 5-year survival in patients who are node positive and who have less than 10% visceral metastases. But greater than 50% of patients tend to be unfit for cisplatin and may need to go with carboplatin or agents that are less likely to provide a response, especially if there's any renal impairment at the time of or as a result of subsequent treatment. Just a picture of EV, an antibody drug conjugate, and you can see the drug binding to nectin-4 being internalized, and then once it's internalized, it causes direct cytotoxicity with microtubule disruption. When the tumor apoptosis occurs, there is significant bystander killing, and so the MMAE spreads to adjacent cells and causes them to die as well. So it is very toxic locally. and there are significant toxicities as a result of that. Immunotherapy. These two agents are now PBS funded. Um, One option is adjuvant nivolumab, which is given bi-weekly for a year and improves both disease-free survival, improves disease-free survival compared to placebo significantly, and uh, especially for patients. Sorry, part of that sentence is missing. Patients who have expression of the disease have a better response. There's also the option of durvalumab given around the time of the surgery, both pre-op and post-op, combined with cisplatin and gemcitabine neoadjuvant chemotherapy, and this can also improve overall survival from 75% to 82% at 2 years. Again, these numbers aren't perfect, uh, and the survival benefit is modest, which is an indication of how significant bladder cancer is once it gets to the muscle invasive stage. Moving on to upper tract urothelial carcinoma, which is 5 to 10% of renal tumors and only 5% of urothelial tumors. Having said that, I have seen a remarkable run of these tumors in the last 12 months, and I don't know whether it's just me or colleagues around the board are seeing them. I'm not sure why it's the case, but um, these arise either as a result of field change in a similar mechanism to bladder cancer versus tumor implantation. In 20% of cases, patients have a concurrent bladder urothelial carcinoma. Um, and once they have their upper tract tumor treated, there is a risk of recurrence in the bladder of 20 to 50% down the track. And so the bladder surveillance is part of surveillance protocol. And a risk of contralateral upper tract tumor. So if they have a tumor in their left ureter, but there's a 2 to 6% risk of them subsequently developing a tumor on the right kidney as well. So surveillance has to exclude that as well. 60% of cases are invasive at diagnosis. The risk factors, again, similar to bladder cancer with a few extras. Uh, Smoking has a higher relative risk compared to bladder urothelial carcinoma. Um, Occupational exposures similar to bladder cancer, hairdressers, painters, printers, people who use photographic chemicals, which is because of the aromatic amines associated with that, as well as people who work in petroleum, dye, rubber, and plastics industries. From my anecdotal experience, I have had one young patient who's developed bladder cancer as a result of working in his father's spray painting factory, and his father developed bladder cancer. And it was really odd when I told him when I treated his stone that he has bladder cancer. He was like, "Oh," and he wasn't shocked because he realized, "Oh, I've got what Dad's got. I have to stop working and go into the office rather than on the floor." Um, I've had patients who are printers and a recent patient and hairdressers, and recently a patient who used to work with photographic chemicals as a hobby and developed this problem. And interestingly, her husband also has bladder cancer. Other causes, chronic infection. Something unique for upper tract urothelial carcinomas are aristolochic acid. Now, this is a chemical found in Chinese herbs as well as wheat from the Balkan areas, and is the cause of so-called Balkan nephropathy. The other risk factor is patients with Lynch syndrome. So third case study is a 56-year-old gentleman who had a CT scan for diverticulitis, which picked up an incidental left upper pole urothelial carcinoma. He had no hematuria, no lower urinary symptoms, past history of kidney stones, an umbilical hernia, pre-diabetic. Previously worked in a printing factory, now a groundskeeper at a school. Ex-smoker from 20 years ago. Prior to that, was smoking 20 cigarettes a day for 20 years. Presentation and evaluation pretty much similar to bladder urothelial carcinoma. Presentation's either painless hematuria, flank pain with clot colic. So pain as a result of hematuria passing down the ureter in about 30% of cases. Incidental disease and systemic incidental pickup, like in our patient in this case study, or systemic features being present if it's a particularly advanced disease. Evaluation is CT intravenous pyelogram, urine cytology, ureteropyeloscopy with biopsy and washings, staging, CT chest, bone scan if symptomatic, consider a PET scan. If you're going to take the kidney out, which you have to in most cases, you may consider a MAG3 renogram for differential renal function to help plan for management of any CKD that may develop in the postoperative setting if you anticipate that as being the problem, as a possibility. In a lot of cases, these patients have an atrophic kidney as a result of long-term obstruction from these slowly growing tumors. So you can get a good idea of their postoperative renal function from their preoperative function. So this is the CT scan, which showed the lesion that you can see in the image, and encompassing pretty much the entire upper pole and arising from the renal pelvis. With this patient, I didn't bother with ureteroscopy. Urine cytology was positive. It looks like a duck. It quacks like a duck. It's a duck. So there was no way his kidney was staying in. So he proceeded to a nephroureterectomy, and you can see the tumor specimen there, which, and this is why I wanted to bring up this case. Our very experienced pathologists at Tissuepath described as a non-invasive, low-grade papillary urothelial carcinoma. Now, it's very hard to believe that the imaging that you can see and the appearance there is a non-invasive low-grade tumor, given how aggressively it's invading into the kidney. But they can only report on what they see, and so they're calling this something that is, for most people, somewhat benign. So, when we stratify upper tract urothelial carcinoma, low risk unifocal disease, tumor size less than 2 centimeters, negative cytology, low grade on biopsy, non-invasive on CT, high risk if it's high grade histology, if the cytology is positive, if there's local invasion, multifocal disease, or if it's greater than 2 centimeters. So despite the low grade pathology at the time of his nephroureterectomy, he does fall into the high risk category. The gold standard treatment is nephroureterectomy with bladder cuff excision. Why do we take the entire ureter and bladder cuff? Well, that's because the kidney and ureter down to the bladder is one unit, which is exposed to the same degree of field change as a result of the either smoking or industrial exposures that lead to development of the tumors. So if you leave any ureter behind, then there's a risk of local recurrence in those areas. And we also have to take a cuff of bladder as well, because there's a 25% risk of local recurrence at that location if we don't take it. If the disease looks like it's invading beyond the kidney, then a lymph node dissection is also considered at the same time. There are options to spare the kidney, and these include just performing a distal ureterectomy and reimplanting the kidney in the bladder, sorry, the ureter into the bladder. This is suitable for patients with disease in the distal ureter where there is sufficient bladder capacity and mobility to perform a reimplantation, and is very suitable in older patients who you're concerned about the morbidity of them losing the entire kidney. It's also an option in situations where you're unsure whether or not the patient has urothelial carcinoma because the biopsies and cytology have been negative, and you don't want to risk them losing the entire kidney. In some cases, we can manage with endoscopic tumor ablation and resection. This requires very close follow-up, repeated ureteroscopies, repeated periods with a stent, and is ideally suited for patients who wouldn't be a candidate for nephroureterectomy. In some cases, you can take out the segment of ureter, but again, that is very rarely feasible. 20 to 30% of patients who have this sort of kidney sparing approach will eventually require a nephroureterectomy. So they need to be carefully selected. So back to our patient. When when we reviewed his completion CT staging with the CT chest, he was noted to have a 2 centimeter pleural nodule. He had an FDG PET, which showed that this was consistent with him having metastatic disease, but despite having low-grade pathology at the time on his nephroureterectomy specimen. And then a lung biopsy was performed, and this was consistent with metastatic urothelial carcinoma. So how do we manage advanced upper tract urothelial carcinoma? Well, management is extrapolated from the bladder cancer literature, so there is a rationale for some neoadjuvant chemotherapy while the kidney is still in situ if there's evidence of high-risk features. If post nephroureterectomy, if the patient's node positive or there's evidence of greater than T2 disease, there is a definite overall survival benefit with adjuvant chemotherapy to the degree that the trial was closed early due to this benefit with a hazard ratio of 0.55 at 3 years. The other option is palliative radiotherapy, again, suitable for patients who are not candidates for surgery, who have multiple medical comorbidities. I have one patient who underwent palliative radiotherapy for a distal ureteric tumor in his late 80s. He was suffering from dementia. He's now in a nursing home, but he's managed to remain disease-free without any complications for a few years now. He does, his bladder wasn't very happy about getting radiotherapy, and so one of the challenges has been dealing with urgency. But he's not suffering from any hematuria and his stent has been removed, and there's no issue with regard to hydronephrosis or worsening renal impairment. So our patient received a split dose of cisplatin gemcitabine with nivolumab for 4 cycles as a result, as treatment for his metastatic urothelial carcinoma, and he continued on maintenance nivolumab. Last year, he had a complete response, but then by March, he had an oligo recurrence in the same area within the lung. So he's recently just completed stereotactic radiotherapy to the right lower lobe where the recurrence took place, and is recovering from that, and hopefully we can buy him some more time. So in summary, urothelial carcinoma dominates bladder cancer. Smoking and occupational exposures are the key risk factors. For non-muscle invasive bladder cancer, transurethral resection plus or minus intravesical therapy if indicated. BCG is the cornerstone of dealing with high-grade and non-muscle invasive bladder cancer and CIS. And you have to consider early cystectomy for high risk or BCG unresponsive cases. With muscle invasive disease, cystectomy, lymphadenectomy, with neoadjuvant cisplatin-based chemotherapy improves survival. Trimodal therapy is useful in selected patients. For systemic therapy, there's growing role for immunotherapy and ADCs like EV in the perioperative and metastatic disease setting. Moving to upper tract urothelial carcinoma, it's often invasive. Nephroureterectomy with bladder cuff is gold standard. Kidney sparing only for low risk disease. And the key principle is the patient's outcome really depends on how early you pick this up, how accurately you assess their disease, stage them, and assess their risk stratification, and getting treatment delivered in a timely fashion to those patients who are fit enough to receive it. Okay, so that's my talk. Thank you for the opportunity to present. I'm happy to answer any questions.
Thanks, Praz. Does anyone have any questions they'd like to ask Praz? You can type them in, or also you can take yourself off mute and ask, or if you have any case studies that you want to discuss, we've got some time. So you're very welcome to ask Praz anything.
Don't be shy.
Don't be shy. So anything on bladder cancer or upper tract urothelial carcinoma, or any other questions you might have? Urological questions? Prostate cancer or no, very quiet, no questions, nothing at all. Okay. So Praz, would you have any specific take home, like for the oh, hang on, there was a question. Are you able to explain how patients are managed via multidisciplinary team?
Sure. So the essentially, once the diagnosis has been made, we complete staging, and it's really just we present the patient in the MDT. We speak to our radiation oncology and uh, uh, medical oncology colleagues and come up with a consensus plan that is most suitable for the patient. A lot of these patients will require neoadjuvant or adjuvant chemotherapy. At the Northern Hospital, we have a very good algorithm for patients moving between uh, um, the urology clinic and the medical oncology clinic in a stepwise fashion to have their initial discussions about cystectomy, have an understanding of what to expect, going across to medical oncology, having their evaluation, having their treatment coming, and once, 3 months down the track, once they've completed their neoadjuvant chemotherapy, then being reassessed in the urology setting, brought back to MDT. So there are multiple time points in which the patients discuss at the MDT to determine their suitability for the different stages of treatment. Because patients may get to a point where they have progression whilst on uh, chemotherapy and may be deemed that they should just proceed directly to cystectomy. There may be situations where patients are no longer suitable for surgery due to complications arising from the chemotherapy, which is uncommon because they're very well selected. There may be situations where the patient is not a candidate for any form of chemotherapy around and they proceed directly to cystectomy. And also it's important that our our radiology colleagues are on board as well, and they can keep an eye out for any red flags that might have been missed during workup to ensure that we do have the most accurate risk stratification.
Right, thank you. We do have a few more questions. If a patient does have bladder cancer or upper tract urothelial carcinoma, how can urinary incontinence and erectile dysfunction be managed?
Sorry, if the patient
As bladder cancer or upper tract urothelial cancer, and if they're experiencing urinary incontinence and erectile dysfunction, how would that be managed?
sure. So if we're in a situation where the patient is keeping their bladder, any incontinence or erectile dysfunction would be considered separate entities that we would deal with. Incontinence falls into either stress or urge urinary incontinence. And usually, if they have urgency in the context of bladder cancer, it's a result of the direct invasion of the bladder cancer or treatment as such that's leading to the urgency. So we would manage that as we would someone who doesn't have a bladder urothelial carcinoma, and that would be with anticholinergics or drugs such as Betmega, Botox in some cases, although we'd prefer to avoid that in patients with bladder cancer. The erectile dysfunction would treat as we would normally treat erectile dysfunction. The times that it would occur in the context of bladder cancer treatment are in the cases of patients who have undergone cystectomy. Um, because we always take the prostate at the same time. There are situations where we can do nerve sparing cystectomy, similar to what we would do for prostatectomy, but again, recovery time is slow, and there's no guarantee that they will have for recovery of erectile function. There are there are forms of cystectomy that involve preserving the prostate for the same reason to minimize the risk of erectile dysfunction. But these are really patients with um, high-grade disease, T1, that's not muscle invasive, that is in a where the primary tumor is quite remote from where the prostate is, and you can feel safe that you can perform this sort of surgery. It's not surgery that I've done. The nephroureterectomy, we're taking out the kidney and a bit of bladder cuff. They usually don't develop any urinary symptoms as a result of that procedure, unless there have been pre-existing symptoms. Um, if patients go on to have BCG therapy and they do develop a contracted bladder, that can certainly present with urgency and incontinence. Um, the standard treatment that's been recommended is for 3 years of maintenance BCG, but a lot of patients actually can't make it to 3 years because they start developing these, severe storage symptoms. And so, if you can get to 12 months, that's great. So ideally 3 years, but 12 months will be great because over time the treatment can be quite toxic. Gemcitabine it can be administered intravesically as well. So whenever there's a BCG shortage, we always switch to gemcitabine, and that seems to work quite well for a lot of patients without causing the same bladder irritation. Sometimes we're very much um, evidence driven and based on historical protocols for what's the gold standard. So uh, gemcitabine is an option as well. Um, those are the scenarios that I can think of in which incontinence may factor into the situation. With a neobladder, incontinence is to be expected initially, especially at nighttime. While the patient is getting used to their new neobladder, they have to sleep with a timer and wake up every few hours to empty their neobladder, sometimes with a catheter if need be. So they need to be able to perform intermittent self-catheterization as well. The Over time, the incontinence improves, and they're able to maintain, a good lifestyle once their bladder has achieved the capacity that it needs to function. But again, Ferrari versus Corolla. Studies looking at uh, quality of life of patients who have um, and patient acceptance of patients who have a ileal conduit versus a neobladder suggest that they're ultimately both equal. Um, in that patients who make certain choices about their they will, if someone really wants to have a neobladder and they have the dexterity and the cognitive ability to handle that, they will have a good outcome.
Okay, thank you. Another question. What's your advice to GPs in terms of how to approach diagnosis of symptoms in their general practice setting? And what is your advice regarding performing urinalysis as a screening method for asymptomatic patients?
um, There is no evidence for screening in for urothelial carcinoma, so I wouldn't recommend performing a midstream urine examination unless it's part of your um, uh, routine general practice, health assessment. And that would, if you picked up microscopic hematuria, then that's an indication to then investigate further with ultrasound or CT, consider urine cytology and referral. Um, Most cases of microscopic hematuria are benign, but those cases that are indicative of significant disease, it's very good if you pick that up early. Um, Sorry, what was the first part of the question again?
Um, Sorry, what do you expect of the GPs in terms of how to approach diagnosis of symptoms?
Sure. So have a high index of suspicion, basically. Storage symptoms. So the big red flags and the big misses are recurrent urinary tract infections in women who have risk factors and haven't had, recurrent infections before, who are in that older category. So a woman in her 70s who's never had, urinary tract infections when she was sexually active in her younger years, all of a sudden starts developing these recurrent infections, visible hematuria. In between the infections, she has persistent storage symptoms, urgency, urge incontinence, frequency. All of these are red flags to suggest that there might be something else going on. Um, in men, these symptoms fall into the category of so-called prostatism and are or lower urinary tract symptoms, and more cases than not are secondary to BPH. But during your workup for BPH, in most cases, you will be performing a midstream urine examination to exclude urinary tract infection because that's one of the complications of BPH. So you'll pick up hematuria if it's microscopic. In most cases, you will be performing a renal tract ultrasound to assess the volume of their prostate, whether the bladder is emptying adequately, whether there's any hydronephrosis, whether you need to refer them on for further evaluation. So just with those two investigations, you'll pick up any hematuria that isn't visible, and you'll pick up any lesions potentially growing in the bladder or in the ureter causing hydronephrosis. And so you'll be able to refer on appropriately in that setting. There are those rare cases where there is no hydronephrosis, but there is something going on. But if there are other things being evaluated, then we can investigate further as required. Urine cytology, if it's positive, they should always get a CT. Urine cytology is an easy test to do, but I wouldn't rely on negative urine cytology, especially with upper tract urothelial carcinoma. In the last 12 months, I've had one recent patient who had hydronephrosis and symptomatic pain secondary to what looked like a ureteric stricture endoscopically. She had negative urine cytology. She had negative biopsies with the largest biopsy forceps you could use, called the bigopsy forceps, and they were negative. So she went on to have a distal ureterectomy in the context of, no obvious disease being seen on imaging. And then that came back as high grade T3 urothelial carcinoma. And so she's gone on to some adjuvant chemotherapy. Um, Another patient came in uh, endoscopically, looked like clear evidence of urothelial carcinoma. Biopsy's negative, cytology negative, kidney comes out, amyloid. Um, the patient I mentioned earlier today um, came into hospital with just a small low-grade tumor in his bladder um, and a normal ultrasound, but the CT scan showed a lesion in the ureter. And I, I'm, I have to say the radiologist underreported the extent of it. I looked at the scans myself, and it's happening more frequently these days where the radiologist is not simply not picking up what's clearly there due to, I don't know, trying to get through being overworked. I don't know. But a lot of cases where you just have to have a high index of suspicion. I make sure that I check all the scans myself for these patients because I've picked up a number of cases where they've been missed, or the disease that's there has not been fully evaluated or reported. So just do your due diligence, have a high index of suspicion, and just do all the tests that you have available to give yourself either the sense of reassurance that there's nothing going on, or those red flags, cytology, hematuria, imaging changes to refer on as appropriate.
Right, thanks. We do have a couple more questions, which we'll get to. Just going back to the microscopic hematuria, because you've answered some of it, but I'll just put the question to you to make sure that we're answering everything that is being asked. Someone has had workup in the past for microscopic hematuria, including cystoscopy. What time frame does that give reassurance, excluding bladder cancer? And what would prompt you to repeat the cystoscopy down the track?
That's a good question. It's a tough question. Usually, if there is a urothelial carcinoma there, it will reveal itself within the first 6 to 12 months. So if you do have a negative initial evaluation, depending on the patient's risk factors and your degree of suspicion, you have to judge each case as it comes. Um, some patients, for example, if I have a younger patient with microscopic hematuria, no risk, non-smoker, no industrial exposures, upper tracts plumb normal on CT imaging, cystoscopy shows normal bladder and BPH, and you can see massively enlarged blood vessels on the prostate. You can very comfortably say that, look, this hematuria is related to prostate bleeding, and you can manage that or just observe it. Um, the If it persists, there may be some value in a repeat evaluation, repeat cystoscopy, repeat cytology, repeat imaging, in a 6 to 12 month time frame. But again, I wouldn't give any firm rules on that. I would judge that on a case by case basis.
Thank you. Just a couple of more questions, Brad. Thank you. On what time is it decided BCG is the best option, or is it combined with other treatments?
So BCG is indicated in patients with carcinoma in situ or high-grade T1 disease who either are not fit for cystectomy or elect not to have cystectomy, or um, it's very reasonable not to have cystectomy for high-grade T1 because bladder preservation in a lot of cases can be achieved with BCG as well. So uh, the indication is high-grade disease, non-muscle invasive, plus carcinoma in situ, which is high-grade non-muscle invasive as well. Um, so they're the indications for BCG. Uh, if you have a young, motivated patient with T1 disease who has additional risk factors, um, you may push them towards early cystectomy versus BCG because there are certain risk factors that are associated with a higher risk of recurrence and a lower disease-free survival during follow-up. And those are those risk factors mentioned earlier: tumor greater than 3 centimeters, multifocality, and concurrent carcinoma in situ. So if they have a 4 centimeter, say you have a young patient in his 50s, comes in with a 4 centimeter bladder tumor, you cut it out, it's high grade, it's definitely T1, but there's carcinoma in situ as well. You would be arguing strongly for him to have a cystectomy because he has some of those risk factors. He will benefit from early treatment. He'll be fit in his 50s. He'll sail through a cystectomy in most cases if he's doesn't have other significant comorbidities. And so those are the candidates that you'll pick. The 91-year-old lady in our scenario was never going to be a candidate for a cystectomy, and in her 90s wouldn't be a candidate for trimodal therapy either. So, but she doesn't have muscle invasive disease, so not a candidate even if she were to progress. So that's where we are limited in what our options are.
Okay, just got two more questions. Sorry if I don't pronounce this correctly. Have you seen any cases of schistosoma related
Yeah.
bladder cancer?
Yes, I had a young patient from Africa who came in with a bladder tumor. He was only in his early 30s, and the concern. I mean, there wasn't anything obvious in the history of uh, playing in swamps or doing any work in waterlogged areas, but when we performed the TURBT, sent it to the lab. Came back showing schistosomiasis, basically active schistosomiasis. We could see the eggs on the TURBT specimen. So he went on. I referred him to an infectious diseases physician for I think it was mebendazole treatment. Or was it praziquantel? Anyway, he had he had the appropriate treatment. However, because schistosomiasis is so rare in Australia, the drug is not available. So the patient had to go to um, the Royal Melbourne Hospital and have a historical supply that was in storage because you can't get it. I thought it was remarkable when I heard that. Yeah, the drug doesn't exist in Australia apart from where it's stored in historically. So I don't know if that's changed, but that was the outcome there. So, schistosomiasis can lead to actual bladder cancer formation. Not in that case of the young man, but you can develop bladder cancer as a result, and that's chronic irritation. And those patients move on to have cystectomy and alleloid conjugate. The biggest series for those patients are from North Africa, Egypt. Countries in those endemic areas have a lot of experience with that, but we see it very, very rarely in Australia.
Right, thank you. And lastly, is there any evidence that nail technicians have a specifically increased risk of urothelial carcinoma?
Yes, because nail technicians fall into the category of industrial exposures. They are smelling that acetone and those aromatic hydrocarbons. They are at higher risk. So that's definitely a yes.
Thanks, Praz. Thank you, everyone, for sending in all of those questions there. That was great. Got lots of really good questions coming in. Praz, thanks so much. for getting so much information into that session and sharing it with everyone tonight. I hope everyone enjoyed it. Thank you for coming along. Hope you've all taken away something useful this evening. Just a reminder to complete the evaluation as you leave the webinar, please. As I mentioned, we always love getting your feedback, so that would be great. The topic for our next webinar will be pelvic floor physiotherapy assessment and management of genitourinary conditions for peri and postmenopausal patients. That webinar will take place on Wednesday evening, the 13th of May. Registrations are open now, but I'll also be sending out a link early next week if you want to register to attend that one. The recording for this particular webinar will be sent out over the next week to 10 days, and I'll also be uploading the CPD to your dashboards. So Praz, thank you so much again, and thanks everybody for coming along, and thanks for all of your questions as well. So we'll say good night.
Thank you.
Bye.